First. Hi. Thank you, Professor. Good morning, everybody. We are group number 3, and we have studied 3D CT image segmentation using deep learning architectures for this project. Today, we will present our findings. So the medical image segmentation problem is essentially about identifying anatomical structures from CT data. As you can see, this is a slice of the brain CT, wherein everything is in grayscale. You can see all the different organs, but it is not so obvious what is what. If you really run a segmentation algorithm on this, this is what you get. You can clearly identify the left and right hemispheres, the white matter, gray matter, thalamus, and everything else. So essentially, the primary reason why this is done is to identify abnormalities to facilitate diagnosis. In real world, this is applied in the following applications, mainly organ volume, metric tumor detection, disease characterization. Over here, you can see that we have a 2D CT image wherein the tumor is clearly identifiable from the segment mask over here. However, in addition to the 2D image, a 3D volume segmentation gives us a great advantage that you can actually see where the tumor is in 3D space. This would be making a great difference in surgical planning and guidance. And with the onset of virtual reality based VR devices, we can actually see the segmented 3D volume in 3D space and hence aid computer aided diagnosis. The main challenges in image segmentation are blur, contrast, and noise. These are the challenges that we will particularly study in this research. So here, firstly, we can see how contrast really affects everything. When we have contrast, the organs are clearly identifiable, but without contrast, everything just looks gray and it is not so obvious what is what. Essentially, blur arises from motion and scattering. If there is blur, you will have smudged edges, which will also make the boundaries between organs not so sharp.
So now that we know what segmentation is and why we need it, let's have a look at how it's done. So one of the classical methods for segmentation is k-means clustering, which is a very popular unsupervised clustering technique. Now, what that means is you don't tell the model about the labels that you're assigning. It kind of figures things out on its own using the intensity. Now, that also means that it lacks spatial context. It does not clearly know that, okay, well, this is this organ, that is that organ. It's just kind of using the intensity values in the image and clustering them out. And this requires a lot of careful parameter tuning, which is not good because you'll have to do that for each kind of organ. Now, if we look at deep learning based methods, UNet is specifically designed for biomedical image segmentation and has achieved great success in that. It is based on convolutional neural networks, which we know are great at capturing features from images. And the best part about the UNet is that it is able to learn from smaller data sets, which is very important in medical imaging because it is tough to gather huge data sets because gathering them and annotating them is quite tough. So let's have a look at the UNet architecture. As you can see, the left-hand side is the encoder part where you take the image, compress it down, basically running a convolutional neural network over here. And at this point, you have all the extracted features from the image. But at this point, you only have the features. And at the end, what you need is a segmentation map, which is the same size as your input image, where you're telling that, okay, this pixel belongs to this class. To be able to do that, along with the semantic information captured over here, we need spatial context. We need to know where these features are located. So for that, we have these skip connections, essentially passing these as input along with the semantic information that we gathered over here. We have the right-hand part of the network, which is the decoder, which takes this small information and upsamples it up to something which is of the size of the input image, where we have the output segmentation map. And it's called a UNet, well, because the encoder-decoder structure looks like a UNet. And now that we know what UNet is and that it has achieved great success in biomedical image segmentation, why can't we use it for CT segmentation? Well, there are a lot of challenges with that. Number one, CT is 3D data, and the UNet that we just saw was made for 2D data. We would have to make up a new model which can deal with 3D data. And the second is that with CT images, generally, the image sizes that we generate are different for each organ. While the unit that we just saw, if we pick a unit model and train it, the model has a fixed input image size. You can't keep varying the input image size to the model, and that's a big problem. Third is that it doesn't quite generalize well over multiple organs. If you train it for over a data set for, let's say, stomach, then it's probably going to overfit to that. It is unable to generalize well over all the different organs that you want to segment. And last is the need for an automated workflow. Because, well, you can't expect a radiologist to capture these images, sit and pre-process them, and then send it to the unit. So to solve that, we have KnowNewNet, which is a robust and self-adapting network, which is based on the same vanilla 2D and 3D units that we just saw. Now, it uses patch sampling for inference and training. Now, what that means is sometimes these images are too huge. And what this model does is it takes small patches of the image and applies the same unit. And this allows it to capture the local features much better. And in the end, as well, in the inference, which I'll explain later, it is able to put together all of these pieces of information and provide a much better segmentation. And yeah, so this model aims to generalize over diverse data sets. That is, it wants the single model to be able to segment all the different organs so that we don't need, separate networks for separate organs. And it's based on an ensemble of the following networks. It uses 2D units, 3D units, and unit cascades, which are essentially multiple networks cascaded together. And what this network finally achieves is an automated workflow right from pre-processing the image to the final segmentation map. And before we jump into our simulations and results, one thing you need to know about how we judge a segmentation model is the dice score. As you can see, if you consider the ground truth and the prediction mask, this is how dice score is defined. And as you can see, as the overlap between the ground truth and the segmentation mask keeps reducing, the dice score keeps reducing. So a higher dice score of 1 is the best you can do, and 0 is the worst you can do.
Based on the unit architecture that we just studied, there is the model called to the total segmentator, which is trained to identify 117 different anatomic structures in an automatic workflow. So we use the NN unit architecture that we just saw for this robust segmentation, and we have 3 different models. We have worked with normal and fastest, where in the fastest just downsamples the given image to compress it and then just runs it on a very low resolution image. This is how the workflow looks like. This is the 3D rendered image of the complete organ segmentation that we obtained from the total segmentator. Here is a transverse view. Here is a sagittal view, and this is a coronal view of the 3D volume that we are going to study.
So we ran some experiments to see how the model performs on the real world artifacts and see its performance. So we experimented with adding Gaussian blur, which represents artifacts caused by respiratory motion or a cardiac motion, or even due to lower resolution CT, and we added white noise, which simulates challenges like low dose CT. So here is some images from experimentation of Gaussian blur. On the top left is the original image, on top right is the blurred image. The blurred image, as you can see, the boundaries are difficult to recognize, and it is more challenging for the segmenter to find the organs and find the image mask, but it does pretty well with a dice score of 0.81 with a sigma of 6.2. This is the complete experiment where we varied this Gaussian blur, the sigma of the blur, from 0 to 20, and you can see the drop off in the score, the model performs pretty well till around sigma of 5, and then it drops off from there. These are some images from additive noise. On top left is the original image, and on top right is the um, a noisy image, and you can see the score for noisy images 0.74 for a noise level of 26 dB. This is the curve which we obtained by changing the varying the noise level. Unlike the previous curve, it drops off very sharply, and so which tells that it's less robust to additive noise. Yeah. The insights are the total segment level was pretty robust to different artifacts. The curves were of different shape for blurring and additive noise. It was more robust for blur as it dropped off slowly, and the fastest we experimented with fastest model which ran 10 times faster than the original one, and it just had like 5 to 10% drop off in accuracy. And we were the insight we got was we can add temporal information by using sinograms which encode the temporal information in the theta axis. Yeah.
So to summarize, this is what we have actually done. So this was about designing and implementing experiments to assess the impact of blur and noise on the segmentation accuracy of the total segmentator model. And we did this using an object-oriented code base on the same total segmentator, expanding it to these experiments, and all of which is available at the repository. To summarize here. Thank you. Thank you.
Okay, this talk is open for questions or comments from either in the room or online. So I see Professor McVeigh's Alex, do you have any questions?
Yeah, can you hear me?
Yeah, we can hear you now.
All right, terrific, thanks. Sorry, I was on the wrong link, I think, to start. That's really interesting results, especially the complete difference between blurring the image and adding what looked like a little bit of noise. Can we go back to the noise results slide? Okay, and so the value of noise is, so this is the drop in signal to noise by 0.25. I'm not sure I understand the relative noise level here. So this, can you explain how you got the first data point at 0.25? Like, what does that? So the total signal to noise of the image dropped by a factor of 4.
So by relative noises, what we mean is the relative amplitude of the a noise. We change the amplitude of the noise which we added and not the sigma, because we saw that changing sigma was not affecting the accuracy that much, and it was pretty constant with the different sigma. So we saw that it varies with changing the amplitude instead of sigma. So we experimented with that, and we normalize the numbers which you see are the relative amplitude with respect to the normalized image which we have.
Okay, so if the first point we were talking, it says it's 0, and then by the time you get to 1, the noise has been amplified. But I still don't really understand that. Tom, do you understand how this access works?
Yeah, I mean, I'm not really sure about the details.
Yeah.
Saying one means what? The noise standard deviation is equal to what?
Not the standard deviation, the peak of the Gaussian.
The amplitude.
Just scale the amplitude of the Gaussian.
So so you can.
Well, the Gaussian is the distribution. So this is a noise level or a blurring level? Okay, well, Gaussian is just the distribution, so the peak is just a
Yeah,
probability. So are you increasing the variance
Yeah, we're scaling. Yeah, we're scaling the amplitude
of the Gaussian noise? But that's just increasing the variance.
Right.
Yes, intern.
Yeah, but that doesn't change the shape of the Gaussian. I
No.
mean, that doesn't change the peak of the.
It's a really interesting result. We don't to keep going and stay on time, but I think one thing that would be really useful with this graph is above it for, say, the first 4 points that are obviously everything that's going on here. You actually showed the image with it, the noise on top of it, so we could kind of see what we're dealing with here. Is it really a signal to noise of 1 when we get to this 1, or like obviously the noise is just crushing this thing, but it would be good to see what that amplitude is. But otherwise, nice job getting it running and applying it with the blurred image. It's interesting how far out it goes, blurring without seeming to diminish the response. So obviously, somewhere in the net, it gets blurred because it doesn't seem to care if it's blurred by Gaussian. I think it was a RMS of two or something like that.
Okay, so in the interest of time, I'm just gonna ask a really quick clarifying question. You did get some questions on the chat, so just respond. If you get questions on the chat, just respond to the chat, and Professor Mavet and I will look at your answers afterwards, because it's all being recorded. I just want to verify. So you mentioned something about a sinogram for the motion. Is that something you implemented or something you're thinking about doing?
That is something we are thinking about.
Thinking of, okay, great. And then this NN UNet, that's the code that you put together where you agglomerate, like sort of put together all these different packages and.
Is an existing model, and total segmentator is based off of it. And we are taking the total segmentator code and adding things on top of it.
I see. Okay, so that's known existing code that you're sort of great, super. Thank you.
Yeah.
Great job. All right, thank you.
Thank you.
Okay, we're ready for group 2. Which is, let's see, going to explain CT to us. So Ryan, Henry, and Ziho, are you here? Yeah, just.
There you go. Do we restart or?
No, just keep going.
Okay. So, the famous Professor Hosfield from 1968, he first proposed the computational method, not only the mathematical wise, that we can that establish the CT nowadays. And from 1971 to 1973, he did a lot of talk during seminars and to present, and he actually built the first CT machine. Remember, in 1973, the machine was based on parallel beams and parallel beams reconstructions. Again, from 1974 to 1975, they developed the second and third generation CT machine, which are using fan beams. But at that time, fan beams reconstruction method has not been established. So it is from 1976 until now that people are working on to improve the fan beam reconstruction method.
Okay, so I just want to go over a mathematical analysis of the difference between parallel and fan beam. So here we have this equation we all know and love, right? This is the inverse Fourier transform over Fourier transform image. But we need to get our Fourier transform image, right? So we all know that we need the radon transform, which is that integral of our image. And then we use the projection slice theorem, right? That says that radon transform is actually a slice of our 2D Fourier transform, right? We use this to get a much simpler version of our back projection equation. Now, here we have S of k, WK, and omega, which are our detector, blur, filter, and omega term. I'm just going to simplify this all into one equation, O of omega. So it just makes our equation seem that much prettier. And we know that we can also transfer this to a convolution as proven in class. And so this is the convolutional back projection equation that we've seen before, right? And so here's just a live reconstruction of the CT image happening. And so you can see the yellow line is the detectors and the green lines are the X-ray beams. And so that was parallel beam, right? That's something we've already seen before. And so, you know, we use the equation of the line. This is the foundation of parallel beam, which is rho takes in two variables, which is rho, the distance between the any two parallel beams, and theta, the angle between the x-axis and the beam. But when we're talking about fan beams, right, we actually need to use different parameters, right, because the reconstruction method is different, right? So when we're talking about fan beams, we're instead using beta, beta being the angle between the y-axis and the middle beam, and alpha, the angle between any two fan beams, right? And so we can actually map rho and theta to beta and alpha using some Clemmert geometry right here. And so what we get is theta equals beta plus alpha and rho equals d sine alpha. And so here's the convolutional back projection equation we've all known to love, right? And if we perform some substitutions, right, based on our mappings from the previous slide and a bit of polar coordinates, what we get is this fun-looking equation right here. And so a little gross. And so you can know that the reassembling of reconstruction actually takes a little bit more effort here. And t is also standing for infinity since we have to change the bounds of integration. And so here's a reconstruction using the fan beam algorithm. And so you can see the reconstruction is a little bit more circular in nature. The sinogram is going to be a bit more wavier, right? And so we can see right here, the sinogram here, again, is a lot more wavier because of those relative angular calculations that we're using, right? And so if we take a look at the point spread function for each of the fan and parallel beams, right, at 1 degree or at the maximum accuracy that the parallel beam is operating at, it still can't even reach the same spatial resolution as the fan beam, right? We see that full width half maximum of 7, so it's more spatially resolute, right? So it's like the parallel beam actually has to try its hardest to try and mimic the spatial resolution of that fan beam. And so in addition, fan beam is actually a lot better in real life because in real life, when we're using a parallel beam, right, the detector and source actually have to translate one at a time to complete one full radon transform. Whereas you can see in this image, when we use a fan beam, it can just flash all at once and calculate a single radon transform. So it's actually a lot faster and therefore a little less susceptible to noise. Hence why we use a lot of fan beam today.
All right, so I'm going to go into some of the applications of the current fan beam system. So as Ryan mentioned, speed is a huge advantage that the fan beam has. And if you're thinking about when you're going to use CT, if you start thinking about like diagnostic testing, you know, just going in, checking up if you have something wrong with your hearts, that's one side of it. But when you go into intraoperative, speed is really the key. Because the surgeon is in the middle of operating, say, for example, the brain. If you have a 5 to 9 hour operation, once you open up the brain, it starts to sag a little bit. And if you're going to put like a brain stimulator into the hippocampus. Well, your hippocampus isn't where the MRI told you it was, the day before. So they bring in, what you have on the right here is the Medtronic Stealth S system, which is combined with a guidance system and they usually have it with a robotic arm to help guide the surgeon and to tell you where they are. On the other side, this is the Medtronic O-arm, a slightly older version of the Stealth system, and they look about the same. They're just this big ring, and they've kindly shown us that it is about comparable or even a little bit better than it's comparable to a standard CT. So in terms of the resolution, despite being like a portable device that can move in and out of the operating room, it still functions pretty well. Other applications for this fan beam geometry is in combination with PET scanning. The PET scanning is itself an entirely different, it can be its own lecture. However, the bare bones is that it uses a radio tracer as a secondary source of radiations. This is gamma radiation, not X-ray radiation. So it's actually able to produce, these higher intensity beams for a high energy CT image, which then is combined with the traditional X-ray CT to produce a combined image that has higher resolution. And this is usually used for, let's say, cancers. We're going to try to distinguish tumors, which is soft tissue, from muscle, which is also soft tissue. So given that we have all these different technologies, if you start looking into, let's say, clinical trials, you might often see that they will say they would prefer a PET CT scan for cancer, for example, but then they'll also accept CT or MRI imaging for their progression-free survival analysis. The reason being PET CT, if you're thinking about the high energy radiation, let's say if you're pregnant, or PET actually does not work that well with people who are morbidly obese. It just does not go through. It doesn't go through with that much mass. It's actually difficult to do the imaging. However, that's fine with CT. So they'll say it's contraindicated for the PET. We'll just accept the regular CT. So although we have a lot of new advances, making sure like the pure CT fan beam is by itself is also really important for cases where the patient can't use it.
So next part, I'm going to talk about the fan beams and parallel beams, the pros and cons. So talking about the pros of parallel beams, so there's a low scatter because the parallel beams basically there's only parallels of the scans. There's no angles between each of the X-rays, but it's actually low efficiency for both generation 1 and generation 2. Well, for fan beams reconstruction, the fan beams method is they have a higher image efficiency, and because it's rotating, so it can reduce the exposure time of the patient to or the X-ray source. So technically, the patient would have reduced doses, but it's harder to run reconstruction, as Ryan just showed algorithm. And if you you mess up with something, there will be a really, really high torsion, high scattering. So I did some really interesting research here. So on the top left is the original image. On the middle part is the linear the parallel beams reconstruction. On the right-hand side, the top right-hand side is the fan beam reconstruction. However, if you have the fan beam, the fan beam technique applied to the original, and then you convert that sinogram to work where the parallel beams reconstruction can work, you have the bottom left image where the resolution is decreased dramatically. And because that you guys know that in MATLAB, we need to set up the distance and increase angle of fan beams. And if you misinterpret that, you got the right-hand image where there's a huge distortion up there. And there's just a few part where parallel beams are still being used for this spec. There is a parallel whole collimator and the path where when the annihilation is happening, so the photon of gamma ray would be on a straight line, so that and the detector would detect it as a straight line. So that's why the parallel beams reconstruction is actually working much better than the fan beam reconstruction here.
And here are just some resources that we've compiled. And thank you for watching our presentation.
Okay, any questions? Well, let's see if Professor McVeigh.
Yeah, that's the teaching graphics are great. Oh, as a question to the entire class, if you have an objection to me using some of your slides or simulations in teaching in years after this, send me an email and say, no, I don't want you to use my slides, because some of these slides are really great for teaching things. Can we go back to the slide that it had 5 MATLAB generated images, and it was a comparison of parallel beam to fan beam. It's like 2 slides back, maybe something like that.
There you go.
Yeah, this one. So so the middle, I'm assuming, is just the inherent MATLAB inverse radon of the raw data. And then the top right is the inverse radon using the inverse fan beam. I'm not sure I understood the differences between these.
So the middle part where I used just the random and irrandom method function, and on the top right I used the fan beam function and the fan beam function. So I'm assuming one is parallel beams and one is fan beams to generate sinogram, and they're using its own reconstruction method algorithm.
I see. And then to get the bottom left, you subsampled the creation of the fan beam data and put it into the direct iRadon inverse transform?
Yes, because I figured out that from 1973 to 1976, where we have second generation fan, which is technically a fan beam, but there's no great fan beam reconstruction method. So I'm taking the sinogram of the parallel beams, and then I use I think it's parallel to fan function. So I convert it into a fan to parallel. I take the fan beams sinogram and then convert it into a parallel beams sinogram. And then to reconstruct it, I find that if we are using a parallel beams reconstruction method to reconstruct the fan beams created sinogram, the resolution decreases dramatically. But there will be normal.
Right.
So
the distortion and smoothing here is due to the errors in the interpolation from the fan data back to the parallel data. Is that correct?
On the right bottom side, where I use the fan beam scan, I use set the parameter equals to, for example, 1. But while I reconstructed, I altered the parameter to 0.5 and 0.25. And then I found if it don't match, there will be a huge distortion here. And distortion is it depends on how much you're way off from your detection parameters.
Okay. All right, great. Thanks for explaining it. Cool.
All right. Okay, next group. Yeah, come on up. You can stop sharing your screen, group 2. Thank you. Okay, and can you unmute yourselves?
Okay.
All right, go for it.
Okay, good morning. Today we're talking about dual energy CT imaging. I'm Gia, this is Shreya, and this is Eric. All right, so dual energy CT is exactly what it sounds like, dual energy. So a regular CT scan would have one energy source. Dual energy has two energy sources. And the reason that we're doing that is because we know that different materials have different attenuation curves based on the energy that it's being hit with. For example, we have iodine, which is a very, very common contrast agent. On the top left here, you see a conventional CT scan. You can kind of see the arteries. It's not as visible, but the second you reduce the energy level to 45 keV, you can see much better differentiation and contrast. So this is a huge advantage of dual energy CT. So for example, for low energy levels, you can see iodine. For high energy levels, you can see different materials like tissue or bone, depending on what you want to see, you can change that. And on the bottom here, we have some dual energy CT images of a fish head, a sturgeon. And in A, you can see 30 kVp, which has very good bone differentiation. And for 50 kVp, you have a lot of good tissue differentiation. And when you want to see both of these details on one image, what you can do is you can overlay them using a material decomposition algorithm. And you can say, hey, I want my bone to be yellow and I want my tissue to be orange. And you can kind of overlay them and see that perfectly there. We'll talk more about that algorithm soon. Some really common dual energy CT structures we can see is for the GE and the Canon structures, we have something called rapid KV switching DECT, which is basically like 1,000 times every gantry rotation. It's going to switch from your low energy level to your high energy level, back and forth and back and forth. And then you'll kind of get this interleaved data that you can use post-processing. And we'll talk some more about this when we talk about photon counting as well. And then you have dual source CT, which is the Siemens. You have two separate sources, and then they each have their own respective detectors. And then you can use your filters and whatever you want to get what you need. So we talked about having a low energy scan and a high energy scan, right? So for example, we have a low energy scan here that has really good tissue differentiation and a high energy scan that has really good bone differentiation. And sometimes even without coloring or material differentiation, you can overlay these two images to get a much better visualization in one image, which is really helpful for diagnosis and clinical reasons. And we have a very simple MATLAB simulation that increases the weight of one image over the other. So you can see how just from having dual energy CT, you can get better imaging.
Okay, so let's talk about the second application of DECT. Some radiologists love colored pictures, which are material decomposed. For example, seeing bone in blue and tissue in red. And this shall be a real display of the real physical values we measure. No AI or machine learning picture analysis. And this is possible with dual energy CT. So we know from the lecture that our attenuation coefficient mu is always made up of a photoelectric effect and a Compton scattering part. So attenuation is always produced by C1% of photoelectric effect and C2% of Compton scattering. But exactly this is the problem. C1 and C2 is unknown. So let's rearrange the formula a little bit and see what we can do. Now in green, you see all components which are specific for a material but have no energy dependency. They go into this A. And now in red, all energy terms which have no material dependency. They go into this F. And these formulas are quite large and complicated, so we just accept them as they are. But the important thing is both A and F can always be calculated in advance. So only C1 and C2 remains unknown in our formula. Okay, now let's say we're having two materials, and material 1 dominates the attenuation just in the photoelectric region and material 2 just in the Compton region. Then we could say our attenuation mu was created by C1% photoelectric effect, which is material 1, and C2% Compton, which is material 2. So C1 and C2 is basically our material decomposition. So what's important to understand here, what we do is the so-called raw data-based approach. We don't really have access to the mu values in our system because we just see the projections from our scanner. But that's not a problem because we can just say the projections are two material mixes as well, so nothing changes in the formula. And assumption number 2, and this is what DECT does, we're getting two projections, G1 low and G2 high, of the exact same scene, just taken at two different energy levels. And now we're able to set up this system of equations for our two energy levels. And in usual, we can assume our body is a two material mix. And this is exactly the reason why DECT works. Bone is calcium, which will be mainly dominated by photoelectric effect. So let's use the first matrix column, photoelectric, only for the calcium values. And water is mainly dominated by Compton scattering. So the second matrix column, Compton, will contain only the water values. So of course, bone also has a Compton part and water also has a photoelectric part, but these are not dominant, so we just ignore them. And that's it. Now we have a system of equations we need to solve for every projection pair for C1 and C2. Then we perform our back projection algorithm. Back projecting C1 will show us a picture with highlighted bone material, and back projecting C2 will show us a picture with highlighted tissue. We can then overlay them in different colors, and we have our material map as shown here or in the beginning. And this also works with much higher precision for multi-energy levels in so-called spectral CT. But we always need to make sure that we really have access to the real physical data.
Yeah, so as mentioned before, now we're going to see how the photon counting, how it works in conjunction with the dual energy CT. So how the photon counting portion works is the detector is different from a conventional CT in the sense that we use a semiconductor in photon counting, and this is commonly made of cadmium telluride. So when an X-ray beam is incident on the semiconductor, it creates electron and hole pairs. So the cathode at the top and the anode at the bottom, and the voltage difference, it helps to separate these. So when the electrical pulse is generated in this, that corresponds to the energy of the beam, which came of the photon, which has come through the sample and hit the detector. So in this way, in photon counting, the energy is measured for each individual photon, which is different from the conventional CT. So this is how it will allow for a better spatial resolution, and the pixel size based on the detector is smaller in photon counting CT. So it allows for more better quality in the perception of the image when it's generated. So these are a few of the clinical studies that we've seen. So photon counting is relatively new as compared to dual energy, and also obviously as compared to the conventional CT. So it's still in clinical studies. So it's still not as widespread as any other form of the CT, but it does have diagnostic applicability and some advantages which when compared to the conventional CT. So there is improved imaging contrast. So there's, because of that, a higher spatial resolution and also a smaller pixel size. So in case of like congenital heart defects or interstitial lung disease, where it helps to more accurately differentiate between smaller structures, like in the lung, you can see the bronchi with more detail than you could in a conventional CT. Then after that, we have reduction in noise and in artifacts. So here it's easier to differentiate between something which is below an energy threshold and the components which are above the energy threshold. So those which are below a certain threshold can be separated as noise or artifacts. So it has been seen in studies that the SNR and CNR scores for PCCT is higher as compared to the conventional CT. And next, we have it functions at lower doses of radiation. So this is something which is particularly useful because there are obviously people who need to undergo multiple CT scans. So when they need to undergo this again and again, it means that they will be exposed to radiation repeatedly. So this helps to ensure that they are subjected to lower doses of radiation with the number of scans that they have to go through. And it's easier to distinguish smaller and complex components. So some of these you can will be shown in the next slide, but like small kidney stones or based on the composition, or also aneurysms in the brain, and which are small and in the finer parts of the vessels, it's easier to identify those. So this is one example where this is, you can clearly see the difference between the tumor morphology in the PC-CT scan compared to the conventional CT scan. So this is in a woman with ovarian cancer. And this is a joint in the middle ear. So here you can see that parts of the components which are smaller and they are not as visible in the CT scan is more visible in the PC-CT scan. So, and this is some of the literature we use to put everything together. And yeah, so that's our topic. Thank you.
Okay, we are open to questions.
Elliot, did you have anything you want to ask?
Well, that was a good review of the both dual energy and the new photon counting stuff. And the citations you've put here, it's a nice list of citations, and the sort of pointing out different specific things. And I'm looking forward to going into these papers actually and looking at those clinical examples in more detail.
Right. Okay, so I think to stay on time, because we're already over, we're going to you want. So if you have questions, just put them in the chat, okay? So can we have group 4? Okay, you got maybe.
Hello everyone, I'm Krista. I'm Kimmy. And I'm Alex. And today we're going to be talking about our investigation of and try to reduce them. So just a little bit of background. CT images are basically gathered from X-ray beams that are passed through cross-sectional area of the body used for medical diagnosis. So as the X-ray sources rotate around, we're able to get these images and see, you know, basically the tissues inside of somebody's body and see what we can do with those. And when you have metallic objects inside of these images, they cause these star-shaped artifacts, which obviously make the images really hard to read. And so these can be caused by a number of things: wires, metal implants, bullets, anything you can think of. And we get these star artifacts from these beam hardening and photostarvation of the photons as they pass through the images. So obviously we need some way to try to reduce this, and one of the things that can be done is an MAR technique, which is done on images after the scanning is completed. So we can do some of these techniques are in painting, which we can do on the actual image itself, and then on the sinogram. Oh, good. And then we have machine learning based models, and then we have a combination of the two of those. So what we wanted to do with our project was basically investigate how metal objects would impact our CT images, and then demonstrate some of the MAR techniques to see how we could reduce those artifacts. So starting with aim 1, we basically just took some images, some two-dimensional CT scans, and put some metal objects in it and said, okay, how does this change our sinogram? And obviously you can see when we have two metal images in this Shep-Logan phantom object, we can see the two metal implants show up in the sinogram as well. But then when we try to do a back projection, we get some star-shaped artifacts. This was also, we had to do some normalization in order to put the star shape in there. So that was caused by us just to simulate what it would actually do. But then we also used some images from Mitsuki Sakamoto, and where it was a water-based beam hardening on an image to reproduce a metal artifact or a hip implant in this patient's CT image. And then we took sinograms of that as well, or produced the sinograms, and then also reconstructed those images. And as we can see, obviously it does not look the same. We can't see that whole side of their hip due to the implant.
All right, so we talked about the MAR technique we're going to talk about today is inpainting, and that can be done on the image or on the sinogram. So the way inpainting works is 2 steps. First, there's a thresholding step that creates a binary mask where 1 is metal or the corrupted pixels that create the artifact, and then 0 is non-metal. And then you use that mask to cycle through all of the pixels, and wherever it's a 1 value and it hits the mask, you use an averaging of the kernel around it in order to kind of blur just that pixel, the corrupted pixel. And so we use Otsu thresholding specifically. And again, the way that works is it first creates a binary mask, turns your grayscale image into black and white. And it does this by determining optimal threshold to separate the artifact and damaged regions from the background. And it does this by maximizing the variance between 2 classes using the histogram of the pixel intensities to pick those 2 classes. And OTSU thresholding can be used for sinogram or image inpainting, but it's more effective in image inpainting, or more helpful, I should say, because of the complex geometry of those star-shaped artifacts. When you're trying to pick out the intensity of a sine wave, it can be a little more obvious because it's just like one bright band. So here's some examples of using the OTSU thresholding to create some mask. Now we did have to go in and use some scaling parameters to just turn up and down the thresholding. I believe just depending on what image you upload, the baseline code that we took from this source didn't create a strong enough mask. It created this bottom right mask, which captured the metal objects, but not a lot of the artifact, the star-shaped artifact. So we created 2 more masks as well to show kind of that variation when you change the thresholding. So this is what happens when you do the inpainting with the blurring of the kernels at the mask points. So it might be a little bit hard to see, but with the low thresholding that includes a bigger mask, you get more blurring, and so it kind of gets rid of more of this pattern of the artifacting and makes it clearer just the actual structures of the image. And as you can see, it also maintains the metal objects. So depending on your application, you might want to see the metal object in your image, so you don't want to get rid of that. And here's the same technique done on the real hip image. You can see that once you have kind of more complex anatomy, the blurring might cause more of a problem, because are you distracted by the artifact, or do you need to see the details of the anatomy? So maybe our threshold parameterization helps you pick different images that you might be able to compare, like more blur versus less blur. And so the pros of inpainting on the image is that it can be applied to various image types. It's relatively simple with those 2 steps and can handle a wide variety of imperfections. Unfortunately, it does not recover all your information accurately because it depends on the neighboring pixels, which, depending on your resolution of the collected data, it might cause more or less blurring to the details of the anatomy that you're looking at. But it's good at correcting small artifacts or missing regions, and it doesn't eliminate your metal object if that's something that you need.
Great. And so the next technique that we're going to talk about is sinogram inpainting, which is done on step prior to generating the reconstructed image. It's where you're working with the projections that you use in the sinogram. It's very similar to OTSU thresholding in that you create a binary mask where 1 is the metal and 0 is the non-metal in order to identify the corrupted pixels. And then for each projection angle in the sinogram, the code goes through and identifies the metal and non-metal sections. And then we go through and we replace these metal affected regions in the mask by interpolating values from the non-metal regions around it. And in this case, we used MATLAB interp1, which is a linear interpolation function, but you can use linear interpolation, spline interpolation, or other for your methods. And so, yeah, it's very similar to like the averaging that was done in the OTSU thresholding. And here's the linear interpolation function, which essentially the y is the value of the pixel and x is the position. So yeah, these were the sinograms that we generated. The one on the left without the metal implants, one in the middle with the metal implants and those artifacts. And then what we did was we went through and did the inpainting technique, which essentially knocked out the most intense bands of the sinogram, and that leaves us with the inpainted sinogram here on the right, which produces the following images. As noted, without implants, with the implants, and then over here on the right is the implanted metal implants and artifacts. You can notice that it does remove the metal implant, and so if you need to preserve that, this method isn't great for that, but it is really good at removing the artifacts. There's some ghosting towards the middle between the ovals of the phantom, but otherwise it's pretty good at preserving the details. So yeah, and then we also did this on another more realistic image, which you can see here. It is a little bit less effective. I think the main reason that we can attribute to this is that in our image over here, the artifacts and implants were a much greater intensity than the rest of the phantom, whereas here the implants and artifacts were of a pretty comparable intensity to the rest of the image, and so it did not have as great of an effect. So, discussing the pros and cons, as you can see, the centigram inpainting does preserve a lot more of the image quality because you're going in through the into the projection data, and you're not working with just a generated image. But there are some limitations that you need the intensity to be a lot greater. You do have to adjust the code a lot more between the different data sets, and so it's not as easily transferable. And if you need to preserve the metal implant, in the cases that we observed, it is a bit more difficult. So yeah, it addresses the artifacts at their source, and it helps to prevent like the propagations into the reconstructed image. Yeah, and that should be the end of it. And in our appendices, we have all of the code from our different techniques. And yeah, thank you.
Great, very nice. And thanks for staying on time. And let's see. I have time for one question. Anyone have a question?
I have a quick question. Then, can we go back to what was interesting was the artifact that remained after doing the sinogram correction on the phantom with the two bright artifacts. This guy here. Now this is pretty interesting, right? Because the artifact that remains is orthogonal to the direction of the what would be the null in the projections from these really bright artifacts. Do you guys look at why that artifact is vertical? You know, it's like a big vertical shadow. Is there any easy explanation for why that appears like that?
Sorry. Is it just because the artifact is hitting it from both sides, you're just getting double the amount of ghosting in that middle region?
Yeah, I guess. I'm trying to figure out a simple explanation for that works. Because if you think of what's going on in the sinograms, so okay, well
Like in the
figure it
sinogram,
out
it could be the point where they're intersecting?
Yeah, is that right? Yeah, maybe. So when you do this, and here
So
you
when you kind
threshold
of
it,
inpaint it out, the areas around it are darker. So it creates a shadow that's actually lighter or darker value than the original image.
Yeah. Okay, cool. We can talk about that offline. Very nice.
Make sure to unmute.
Yes, I have unmuted.
Okay, thank you.
Okay, awesome. Hi, everyone. So we are group 8. My name is Rosie, this is Maggie, and this is Pintia, also known as Yuna. And our project topic is the ability to detect coronary artery calcium when considering differences in slice thickness. So before we even go into our project topic, Yuna will describe what even is coronary artery calcium. I can. Okay, so at first, let's talk about what is a coronary artery calcium. So the coronary artery is a major blood vessel that supply the blood to our heart. And if the calcium just build up on the wall of our coronary artery, then it becomes a coronary artery calcium, and which also means CAC. So why is it important to detect the CAC earlier? If we can detect the CAC earlier, then it can help the doctor to assess the risk of heart disease for the patient before the situation gets worse. So the traditional CAC scans are performed with CT scanners that produce the thicker voxels. So it means that only the large enough calcium can be detected. And due to the development of technology, right now the modern CT scanner can image with the thinner voxel size, so allowing for the improved detection of the calcification. So right now we will do some review of voxel and slice thickness.
Okay, so I will explain a little bit about like what does voxel mean. So imagine there's a cube, a cube representing a 3D section of our body, and we just like take a cross-sectional slices of that cube, and then we break it down into a tiny individual blocks. And in CT scans, each small block is represented as 2D pixel. But if you look at it in 3D, it's called like voxel. So that brings up what this like thickness is. So in CT scan, the slice thickness is related to the CT detectors because it captures X-ray signals as they pass through the thin slice of the body. And also the height of the detector along the Z-axis controls how much of the body is included in each slice. And next, our hypothesis is thinner slice thickness have better detection of the calcium. So you can imagine your heart as a loaf of bread and slice thickness as how thick each cut is. So the thinner the slice thickness, the more slices you can take, so you can see every layer in great details, including small bits of calcium in the coronary arteries. And next, I'll hand it over to Rosie for the MATLAB simulation related to our hypothesis.
So everything we've done in this class has been so far in 2D. So now how do you scale this to 3 dimensions to account for differences in slice detection? So it's somewhat similar to what we've done previously in homework 3. But the first step that we want to do is initialize a empty 3D volume. And this is just supposed to represent a patient's heart. And then to represent our calcium, we've placed a small object in the middle. And it's kind of hard to see, so we painted it red in the middle, as you can see right there. And then in the Z dimension of this cube, this would be the total number of our slices. So the second step after we've initialized this volume is to then apply the radon transform to each individual slice. So in this case, it'd be 150 slices. And our radon transform is just, simulating what a CT scanner would do, is taking multiple projections across various angles. And then after we've taken the radon transform, we're now adding noise to it to simulate what realistic scan data would look like, because of course, when you're in CT, there could be movement from the patient, as well as just noise from the electronics of the machine, as well as radiation scattering. And now this is the part of where we've introduced, okay, we have multiple images, but how do we reconstruct this into an actual 3D image? So what we're doing to simulate different slice thicknesses is we're grouping our each individual slices according to slice thicknesses that we want to test. And then these grouped slices get all added up and averaged into one new thicker slice. To explain further what I mean, if you're looking at the simplified image in the middle right here, if we can just imagine that we have a cube that has 8 slices, but we want to test for a slice thickness of 4. We're then going to group all of these slices by groups of 4, add them all up, and then average them into one larger slice. I don't know if you can see it with the image on the slide, but hopefully on Zoom you can. And then lastly, now what we're doing to reconstruct the image is we're taking this larger new average slice and applying the inverse radon transform to fully reconstruct the image. So what you're seeing right here is the result of our simulation from how are we taking this very small object in a large empty volume into the reconstructed version. And please note that this is a zoomed in version of our entire object because when we're reconstructing it, a lot of noise gets introduced. And if we just were to show you the full object at scale with so much noise, it's very hard to see this small piece of calcium. So hence, this is why we've kind of zoomed in so you can see what this reconstructed calcium ends up actually looking like. And now to talk about, the image quality for when you're doing a smaller slice thickness versus a larger slice thickness, we're going to do a short review on resolution. So resolution is just the ability of an imaging system to detect fine details. And this can be described through, of course, our point spread function. And the point spread function is just your signal or object, how much of this is spread out across over your entire image. So you would expect if you have a higher resolution image, you would have a thinner point spread function, which means it's able to detect small details very finely. And then the inverse of that is a lower resolution would have a much broader, wider point spread function. And then to quantify this even further, what you can do is calculating the full width half max. And all that is it's just the full width of your point spread function, but at your point spread function's half of its peak amplitude. So now we know what resolution is and how to quantify it. So we're just going to translate that into our simulation. So what you're looking at here is a portion of our 3D image. You can see it across the changing Z planes. You can clearly see here that for a smaller slice thickness, you can see our piece of calcium is very well defined with clear boundaries. Although when you're moving to a larger slice thickness right here, it's very hard to truly tell what the boundaries are because they're a lot more blurred. And not only are they blurred, but it has this weird stretching effect. And this stretching effect is as a result of us just averaging so many slices into one new single slice. And to further prove our hypothesis, we then looked at this quantitatively by plotting our point spread function. So you can see here that a smaller slice thickness does indeed lead to a higher resolution through the, again, thinner point spread function and a smaller full width half max value in comparison to when you have a larger slice thickness. And next, we're going to look into how SNR compares, but first, Maggie will have a review.
Yes. And going on to our second analysis for image quality. So a little review on what signal to noise ratio means. So it indicates how clearly the target stands out from the background noise. So mathematically, the difference between the target and background is divided by the standard deviation of the background noise. And in the left side of the picture, you can see as SNR decreases, the noise is getting larger noises in relation to the signal. So when we look at our SNR result for both thinner and thicker slices, we saw that for a thicker slice, it will cover more in our detector. So it should increase the number of our signal. However, our result shows that it has fewer signals in thicker slice, which is not matching with the theory. So we're thinking that there might be some limitation here. So we're going to talk about explain the limitation of our simulation.
Okay, so our limitation of simulation is to be the partial volume effect. And this is the phenomenon that occurs in a medical image if your voxel size is larger than the structure you are going to image. So the value of a single voxel will be the average of the signal from multiple types of tissues. So the effect will reduce the clarity of the image and blur those fine details. So let's take a look at this picture. So we assume that the darker one is a noise and the lighter bar is our target. So you can see that the three pictures in the middle, it occurred the partial volume effect. So in our MATLAB simulation, our voxel size is larger than the target we are going to image. For either the slice thickness is 6 millimeters or 25 millimeters. Our thickness of calcium is only 3 millimeters. So our image will occur the partial volume effect and at the voxel where the calcium is located. So we know that theoretically the SNR will increase if you increase your thickness, but because our result is shown the opposite way. So it might be because of the influence of partial volume effect. So which leading to the decreasing amount of our target intensity is larger than the decreasing amount of our standard deviation of a noise. And this is the source we're using. So thanks for listening.
Okay,
That's great. Thank
ahead.
you for that demonstration. I think that's exactly what's happening is your signal is going down faster than your noise is going down when you basically add thickness to the voxel. The partial volume is taking your signal down to the baseline more quickly than it's taking the noise down to the baseline. And that's why you're seeing this result.
Yeah, can you go back to the in-plane? Go back a few slides to where you show the images.
Right here.
Yeah. So the vertical axis is the Z.
Yes, so this is across multiple slices.
Okay. So why does it look dark? Like why does the middle look dark?
The middle for this.
Or
larger
even there,
slice
or is
thickness.
that just, yeah, like there's,
You're
is the calcium that bright spot or?
So the calcium is the darkness that you're seeing, and the
Oh,
extra dark is just the
okay.
boundary of the calcium.
Got it. Okay. Okay. And what's that white? Why is it asymmetric? There's like a white thing on the top, but there's no white thing on the bottom.
That's interesting. That's something we honestly haven't considered, but I'm assuming it's just when we're averaging, it must be something about the noise interacting with the actual object, because I mean you can see it here as well, but the kind of like upper and lower portion of this kind of white effect that you're talking about, but perhaps this isn't as easily seen just because it's on a smaller size thickness.
Okay, great. Thank you. Nice job. Okay, last but not least, we have group 6. So if you could come up, I know we're running a little late, so we'll make sure you have enough time.
There, can you guys hear me? I think it's working.
Okay, they can't hear you, they can put it in the chat. All right, go ahead.
Hi, everyone. We are group 9. We will be presenting on our simulation of motion effects, CD image quality using MATLAB, where we analyze parallel beam, random transforms, and fan beam reconstruction. We have divided our presentation into 4 parts, which are concepts, our color structure, our results analysis, and the conclusion. Quick overview of parallel versus fan beam. Parallel beam CT uses X-ray source which come from parallel lines, as seen in the image here. We go across the object, Whereas for fan beam, we have a single point source where the X-rays diverge in a fan shape as seen in the image here. A little bit of a comparison between both of them. Fan beam has a higher efficiency, but it comes at the cost of more complex algorithms and formulas for the reconstruction. But it is what we see in more modern CT scanners in the clinical space. Whereas parallel is more used in research and early CT scanners because of our simpler algorithms and faster results due to it. And some of the key MATLAB functions that we are going to use for this analysis are for image generation, the phantom, which generates a synthetic image of different ellipses and a different gradient that can be analyzed. For parallel beam reconstruction, we use the radon and iRadon functions. The radon function focuses on generating the projections and calculating the line integrals between them to calculate the projections and then store the data in the sinogram, while the iRadon takes the data from the sinogram and computes the 1D Fourier transforms to obtain a set of transforms that cover the entire 2D space of the image. We can then inverse transform them and reconstruct the image by back projecting it by summing those projections back into the 2D space. And then for the fan beam reconstruction, we use the fan beam and iFan beam functions. The fan beam function first converts the fan beam coordinates from Cartesian coordinates using the formula here, where r is the distance from the source and s is the distance along the ray. Once those are converted, we take the line integrals similarly to the parallel beam, and then store those projections in the sinogram, whereas the iFan beam, first the function takes the data and converts the fan beam projections into equivalent parallel beam projections by using the two variables theta and t, where theta is the result from theta plus b, where the original theta is the angle from the source and the beta is the angle along the ray. Using this new equivalent parallel reconstruction, we take the line integrals again and back project them into the 2D space to reconstruct the image.
The second part is the code structure. We use written, and the left one is the original, the right one is the reconstruction, and this is the sinogram. And the fan beam reconstruction, I want to explain in detail. First, the D is the distance from the is in pixels from the fan beam vertex to the center of rotation, and the MATLAB gave us the formula to calculate the D. And the fan rotation increment is this one is to define the rotation angle, and we set 1 to ensure the rotation angle is 360. And the fan sensor spacing is to detect the number of detectors. And if we set to 1, the detector number is 61, and we tried that the reconstruction image is blurred. So and the radon function in MATLAB, it has 367 detectors, so we set this parameter to 0.167 to let the radon and fan beam has the similar number of detectors. And this is a simulation of different rotation angle of the fan beam reconstruction. On the left is its rotation angle is 180, and we can see that it couldn't be reconstructed successfully. That's because we need the rotation angles to capture all points of the image, and the minimal degree is 243. So and so at last we chose 360 for both radon and fan beam. And this is the simulation of motion. We choose the phantom function to generate an image of a height phantom. We use the E matrix to define the phantom and simulate the motion. When all biological motion is analyzed by CT, 3 categories of motion become apparent. The first is rotational and off-axis shift. The second is the contractile and expansive motion, and the third is z-axis motion blurring. Because we choose the phantom function and it generates a 2D image, so we choose these three motion types. And for example, if we want to move some ellipse, we could change A and B. If we want to expand some ellipse, we can choose the we can expand the XO and YO. And if we want to do some rotation, we can change the phi. This is an example of translational motion. We translate some parts in the phantom per 120 degree. And this is the rotation example. We can see that this ellipse has a rotation motion, and this is scaling. And finally, the code structure, we initialize some metrics and define the theta at first. Then we put the projection result of every theta into every row of sinogram. And every 120 degree, we simulate one motion. After that, we use the sinogram to perform the reconstruction.
Okay, now let's turn to the resultant analysis. To better compare the difference between parallel beam reconstruction and fan beam reconstruction, we use continuous motion and sudden motion to investigate the effects of motion on reconstructed images. Firstly, it's about the continuous motion. We simulated the hurt motion as it can be seen as sinusoidal. And here's the parameters typical of two specific organ motion types documented in the literature. Consequently, we add the three kinds of motion: translation, scaling, and rotation, as mentioned above. And for each three angles with the sine function. So here's the result for continuous translation motion. And on the left hand, we can see the GL theta function, and the first one is the GL theta without motion. The second one is radar transform with motion, and the last one is fan beam reconstruction with motion. And on the right hand, it's the reconstructed image. Compare these two images, we can notice for parallel beam reconstruction on the left hand, it has somewhat shifted or translated appearance, and it also has some parallel straps. Well, for fan beam reconstruction, and it has rotational artifacts with radial straps. And also we conducted scaling and rotation, and the results are similar. And then in addition to continuous motion, we also add the three kinds of sudden motion. Firstly, it's also translation. We add motions near the angle 150 and 330, as we can see from the GS theta function. And then here's the reconstructed image. After zooming in and highlighting the artifacts, we can find that the parallel beam reconstructed image has parallel artifacts, while the fan beam reconstructed image has radial artifacts. And then we also conducted scaling and rotation also at the angle of 150 and 330, and the results are similar. So finally, to conclude, in this project, we simulated parallel beam and fan beam reconstruction, and then we added different kinds of motions, like translation, scaling, and rotation for both continuous motion and sudden motion, and compare the differences of reconstructed image. Like the parallel beam reconstructed images have parallel artifacts, while the fan beam reconstructed images has radial artifacts. And that's because the geometry of their respective X-ray paths. So this is our reference. Thank you.
Great. This open for questions.
Yeah.
Oh, wait, did you have a question over there?
Hi, Tom. My Wi-Fi went down at slide 3 and I just got it working again. Sorry about that.
You can see the, so,
Yeah, you got it recorded. I'll watch that.
yeah. So what was the, so in the, for the sudden motion, you had the nice demonstration of parallel versus sort of fan beam sort of artifacts. For the continuous motion, can you go over what was the main difference between the parallel beam and fan beam artifacts that you saw?
Yeah, the parallel beam reconstruction. Well, there's you can see this ellipse. It has some like shifted motion, and it's not the rotation one, but for fan beam, it's like a rotation artifacts.
I see. So you're thinking because it's rotating the whole time, or?
Oh yeah.
Okay. 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 Thank you. So I think we're not, well, I guess we're a little late, but so thanks to everyone. Great job from all the groups. Let's see. So yeah, so we'll meet here on Wednesday for the next 6 live groups. And if you're a youth citizen, don't forget to vote. Okay.